Hi, this is Brian Kim. I want to share with you this case of a patient who had an unhappy visual result after having a Symfony lens placed. This patient had a Symfony lens put in by another surgeon out of town, and she tried to adapt with the lens, but visually she just could not see clearly the way she wanted to. And so you're going to see a 6-month post-op in the back IOL exchange for a monofocal lens, and it's going to be set for a near target. And I'm going to use a 27 gauge needle technique with the dispersive viscoelastic syringe, and I'm going to be able to lift the rhexis edge off the optic and then proceed with performing the explantation. So you can see this is the Symfony lens. The lens is well centered in the capsular bag. The posterior capsule is still intact. And again, like I said, I did not do the original surgery. And because this surgery was done a while ago, I'm going to go ahead and make my own incisions here. I'm going to make my incision with the paracentesis blade first on the right side and then the left side. And this is intracameral epinephrine. And then I'm going to take the dispersive viscoelastic and mount it on a 27 gauge needle. Going through the left side incision, I'm going to go ahead and push the viscoelastic into the eye, coat the corneal endothelium. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. With that same needle and dispersive viscoelastic, bevel down, I get under the rhexis edge. I start sweeping side to side and I push viscoelastic, and I'm essentially visco separating the capsule from the optic. It's very important to make sure that the needle, since it's sharp, doesn't go past the optic edge. If it goes past the optic edge as you sweep side to side, you're going to encounter the fused anterior and posterior capsules, and you don't want to accidentally puncture the capsule. And so it's very important as you're sweeping side to side with the needle, don't go beyond the optic edge. And with the cohesive viscoelastic cannula, I get under the rhexis edge and further visco separate the capsule from the optic. I do that from that position and then switch to the main incision and continue to separate, going around 360 degrees, and then I switch to the right side incision and I'm doing the same thing. So you want to get 360 degrees of visco separation of the rhexis edge off the optic. You can see I'm going subincisional now. And then I'm going to separate and focus on separating the optic-haptic junction and spending extra time making sure the haptic is separated from the capsule. You can see that the lens is already loose, so I get underneath the edge of the optic on the right side, push a dollop of cohesive viscoelastic, and by doing it this way, you know the cohesive tends to ball up, so I'm able to keep that posterior capsule back and essentially cause good separation of the posterior capsule from the lens. And with the Sinskey hook, you can see I'm grabbing the optic-haptic junction, pulling it centrally, and you can see how nice and loose it is. And then I'm grabbing the haptic, bending it inward, and I'm able to pop the haptic into the anterior chamber. And then through the same main incision, I'm going to tease the optic away, and then easily I'm able to lift, and then it causes a trailing haptic to just fold and then go into the anterior chamber. And so these are the IOL holders and forceps. I go ahead through the main incision, grab the IOL with the actual teeth of the scissors to lift it up, grab it with forceps on the left hand, and then I'm cutting, but as I'm cutting, I have the scissors sideways. By doing it this way, the scissors underneath the lens won't go towards the posterior capsule as much. I'm limiting the excursion of that blade posteriorly. And so as I continue to cut, I make sure I'm mindful, stay away from the posterior capsule as well as the anterior capsule. And then very carefully, I'm able to tease the scissors off the lens with the forceps on the left side, and then switch the scissor on the right side for forceps. I focus on the right piece because with the right piece, you can see the haptic is going to fold on itself. So I start with the right piece, start to pull it out of the incision. And as I do this, I'm very carefully, slowly doing this. And then I'm using the left forceps to guard the cornea. So again, the left forceps is acting as a guard, shielding the cornea endothelium from trauma if the lens piece wants to come anterior. And then it is able to come out nicely. Now with the left side piece, you see how the haptic is actually pointed towards me. You don't want to do that because then it's going to act like a hook. It's going to grab something. You don't want it to grab the capsule. You don't want it to grab the iris. So I'm going to turn it 180 degrees and then using a two-handed technique, gently rotating that lens, grabbing the distal side, again, rotating it 180 degrees, grabbing that tip, grabbing that piece and then pulling it out. As I pull it out, because now the haptic is oriented in such a way that it's going to fold on itself, this is a safer way to do it. And as I pull the piece out, I'm using the left side forceps, again, as a guard and a shield to protect the corneal endothelium. As the lens piece comes out, you don't want that haptic to point up and scratch the cornea. Using that forceps as a shield, you feel much more confident that it's going to protect the cornea and not cause any damage to the eye. Of course, single-piece acrylic lenses are very malleable and easy to remove. Some people just yank the whole piece out. Some people have these interesting maneuvers. But using a two-handed technique, cutting it into smaller pieces, and then protecting the corneal endothelium the way I do it is the way I feel very comfortable removing these lenses. So this is a single-piece acrylic lens. I push some more cohesive viscoelastic to fill the bag, and then I'm delivering the single-piece acrylic lens into the capsular bag. Making sure that the bag is nice and full, but I don't go in too aggressive. I'm going to go in with the infusion first, make sure the bag is completely open, and then I'll put the rest of the lens in. So I go in with the INA, activate irrigation, and then very carefully making sure the haptics go into the bag. And then I'm going to go underneath the optic, tilting it and removing the viscoelastic from within the bag, and then repositing the optic back down. And then I'll remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had a Symfony lens. Now this is not about criticizing the Symfony lens. I like the Symfony lens. I put it in a lot of patients. Patients get great vision. But this is a problem. Not everyone is the same. And so this patient got that lens, was hoping for a good range of vision, but the rings bother her. And some people just can't adapt to the technology. Remember, our natural lenses are the crystalline lens. They're made of protein. They're 13 millimeters in diameter. They're big and round like a UFO shape. It's different from the lenses. These lenses are 6 millimeters in diameter and they're thin. And so they're just completely different design, but we're using man-made technology to try to duplicate what we were born with. And it's just not always perfect. And so it's not because the surgery was not perfect, it's because the technology and patients' brains and eyes are not the same. So I use the analogy, it's like if you had a pair of shoes and people were bragging about how great a shoe is and it's the world's best shoe ever and they love it and they don't buy any other shoes except it. And then you decide, okay, I'm gonna go with that recommendation, I'm gonna buy that shoe, and you buy the shoe and it's terrible. It doesn't fit right, it hurts. And that's because everyone's different, right? Some people have narrow feet, some people have wide feet, some people have flat feet, some people have high arched feet, and everyone is built differently. And so the point is, it's not the technology that's bad, just like that shoe. There's nothing wrong with shoe. It's just that there's an incompatibility between the technology and the person. And so that's why you can't go by what other people say. People say, oh, you know, this surgery was this, the lens was this, I would do this, I would do that. And it's okay to get recommendations from people because that's what people do. You go on, Amazon.com and you read all the reviews, but you have to take all of those things with a grain of salt. Well, first of all, those things are commodities. Those are things. This is a lens that's going into your eye. And so the difference is you are not other people. You are your own unique person. And so I think that's the first thing. And then the second thing is, if you as a surgeon are putting a lot of these lenses in, it makes sense for you to know how to take these lenses out. And so that's really my opinion. If you're going to put these lenses in, you got to learn how to take them out. Now, this patient, like I said, didn't feel comfortable with their surgeon doing it. So they found me and had me do it, knowing that I've done a lot of these types of surgeries. I have a lot of experience taking out lenses, in particular lenses that other people have put in. I always warn the patient, I didn't do your original surgery. I have no idea to expect. Maybe there could be zonular problems, there can be capsule problems, but I'll certainly do the very best I can. This patient had, again, surgery 6 months prior, but you see how easily I was able to remove the lens. The surgeon did a great job in getting good rexus overlap, 360 degrees. The posterior capsule was still intact. This is actually a rather routine removal of a lens and replacement with a monofocal lens. This patient wanted to have near vision target, so I gave her near vision target, and she was ecstatic. She's able to see everything in her house clearly without trouble, and she doesn't mind wearing glasses to see far away. But again, if you're going to put in these specialty lenses, it really makes sense for you to know how to do these surgeries, and if not, have a particular surgeon who you know, have a relationship with, who does a lot of these surgeries, so that when you run into trouble and the patient's not happy, that they can actually do the surgeries, remove the lenses for you, and put a new lens in. And so again, this is a patient who had a Symfony lens, wasn't happy, and I put in a monofocal lens using a 27 gauge needle technique on dispersive viscoelastic, bevel down, lifting the rexus edge up, and then following with a cohesive viscoelastic cannula. And this patient ended up very happy with an exchange for a monofocal lens. So I hope this was helpful to you, and I thank you for your attention.